We were
Okay.
trying for Sunday. I had just gotten back from
Yeah, yeah,
St.
yeah.
Louis for that
St.
the
Louis.
board course.
Yeah.
But
How was it?
yeah, no, that was my fault. It was great. Oh man, I have a lot to study, Dr. Leffler.
Yeah. But do they give you like a booklet of some sort, like, kind of a cheat sheet of what you need to know?
Well, they actually give us. They're the authors of the oral surgery board, the oral board exam review for OMFS. They're the authors of that book.
Okay.
So, and they got a great group of guys that cover every single topic. They're all absolutely brilliant, and they're actually really down to earth. They're really easy to talk to too, which is nice.
Yeah.
And so yeah, and we went through a lot of cases. They gave lectures on like, yeah, you should know this, But then it was also every afternoon for the 3 days we were doing like cases to give us mock cases, which was outstanding. I mean, you really need that for the oral board exam because it's
Absolutely.
different. But
Yeah.
so anyone listening to this podcast that's in oral surgery, there aren't oral boards for general dentists, or I don't know if other specialties, but in oral surgery, we have two parts to the board of certifying exam. First part is written, multiple choice, and that qualifies you for the part two, and part two is oral. So you have to go and sit in front of a panel of dentists, and they rotate through, and they go through cases with you, and you have to, they just fire questions at you. It could be anything to do with anything. It could be the mechanism of action of ketamine, and you have to answer that on the spot. And then they bring you through these little scenarios with the case that they're presenting. It's all verbal, so it's different from any other test we've taken before. The closest thing you could say is like an OSCE in the medical school portion, but it's not it. So it's I think it's really good. I'm a big supporter of studying for this exam because it's like at the end of residency, you're really going in on like cases and stuff, but this is kind of like a good summary of everything we do in oral surgery, and you need to know at least some surface level of a very wide variety of cases. So it is excellent. I do believe in it. I wish the board I guess the board administrators would kind of, but so far so good. So test in February and we go.
Yeah. I mean, I always felt that taking the boards made me a better surgeon. I mean, you figure like it doesn't make me more dexterous. I can't do stuff better. But my program director, who's no longer with us, he said he had
Did you have Harrigan?
no, it was after Harrigan, Stuart Super.
Oh,
And,
super.
yeah,
Yeah.
he used to say, I'd rather have a mediocre surgeon who can think well than an excellent surgeon who can't think. And that's absolutely true. So one
It
of the
is.
many things I learned from him.
That's a great point. It does get you to be a better surgeon. My one critique is that, it doesn't lower your malpractice fees. It doesn't increase your insurance reimbursement, and it doesn't. There was a third thing. There were three things I was talking with people this last week, and that it's like board certified oral surgeons. There should be something, as far as benefits go. But I do believe that it makes you a better surgeon all around. I really
Yeah,
do.
it's a thing for, if you're an oral surgeon, you're achievement oriented, and it's the highest you can go in your profession.
Clinical.
So that's what it's about.
That's right. Hey, let's get into
Let's go.
this case. Let's do it. I got it right. Come on, come on. Here we go. There we go.
There we go. That's it.
Okay. Yeah, I reviewed this one, and this was an interesting one. But these are all interesting. I love it. So yeah, let's. You want to get into it?
Yeah, let's get into it. Of course, just interrupt whenever you feel like it, and take it from there. And do you want to do like the disclaimer thing at this point, or to get it out of the way?
Great idea. Let me find that.
I know we have to do it.
Thanks for reminding me. Yeah. Sometimes I love to, because it's not every day I get to see and chat about like the boards exam stuff and,
Yeah.
and real life stuff, and I like to know how you're doing. So, okay, and I just summarized it. Okay, here we go. So, to introduce right here with Dr. Marc Leffler, I know that these case presentation includes circumstances from several different closed cases in order to demonstrate certain legal and risk management principles, and that identifying facts and personal characteristics are modified to protect identities. The content within is not the original work of MedPro Group, but has been published with consent of the author. Nothing contained in this article should be construed as rules for establishing a standard of care or as legal, medical, or dental advice, because the facts applicable to your situation may vary or the laws applicable in your jurisdiction may differ. Please contact your personal or business attorney or other professional advisors you may have any questions related to your legal or medical obligations or rights, state or federal laws, contract interpretation, or other legal questions. And this is Dr. Marc Leffler, our lead dental risk consultant at MedPro. So let's do it.
Okay.
I just unshared.
All right. Hey, whatever makes you happy is good with me. But I can start talking about it. If you want to pop it up, that works for me. So
Got it.
this
Yep.
is a case which does involve two practitioners. The oral surgeon is the more critical practitioner to the case, but in realistic fashion, the case comes to the oral surgeon on referral from a general dentist, and which is an everyday circumstance among oral surgeons. So, as oral surgeons know, you kind of inherit the patient that you have in front of you, whatever conditions they might have, whether they're dental, medical, across the board, you take on that patient, you take them as they come. So, in this situation, very briefly, it's a patient who was a longstanding patient of the general dentist, but hadn't seen him for something like a year and a half prior to the subject incident. And she had had a crowned upper anterior tooth for a good number of years, and she started to have symptoms. So she sees her general dentist. He takes a radiograph, finds that there's a very significant sized periapical lesion, radiolucent at the apex, and determines by other means as well that this tooth is a candidate for root canal therapy. Explains everything to the patient. Patient is fine with it. He begins the procedure, and in something that's not very uncommon, I'll put it in those terms, one of the files separates. And that in and of itself is certainly not necessarily negligent. But in this case, a portion of the file that separated off ended up slightly beyond the apex of the tooth and projecting into, at least radiographically appearing so, into that periapical radiolucent area. So this dentist happened to be pretty experienced with doing endo procedures, and he worked on it for a while to try to pull out the separated portion of the file and was unsuccessful. There's a little bit of a lesson in here, and that is that if you're doing endo or actually any procedure, any instrument that you place into the mouth, when you take it out, you need to just look at it to make sure that it is in fact complete, that nothing did break off, which was the case here. So the general dentist said to the patient at that point, I can do one of two things for you, because the patient was adamant about keeping the tooth, upper anterior tooth. Excuse me. And the dentist says, I can't do any more with it, reach the end of my abilities. So I could either send you to an endodontist who can work further to try to recover the separated portion of the file. Excuse me. Or I can send you to an oral surgeon to have an apicoectomy done. His sort of tacit advice was, I do a lot of these root canals and I'm pretty good at it. I don't think that an endodontist is going to have much more success. And the patient went along with that, and the patient is referred to an oral surgeon whom the dentist contacts, says, I want to send this patient over. The oral surgeon says, sure, I'll see your patient as soon as she gets here and we'll take care of it. So the patient comes into the oral surgeon, and she was already anesthetized, but the oral surgeon gave a little bit more. And the oral surgeon goes ahead and makes a semilunar incision through the gingiva above or north of the crown, shall I say, opens up and sees that the apex is staring right in the eye. There is a portion of the separated file that is sitting there. There's a lesion, which looks clinically as it did radiographically. Oral surgeon goes ahead, and it's a very straightforward procedure by description. An apicoectomy is performed. The separated portion of the file is removed. The lesion is removed, and everything is sutured closed after the area is irrigated, and there is a retrograde placed into the remaining portion of the tooth. Everything seems to be okay. Patient is discharged, and the patient comes back at a scheduled postoperative visit for suture removal. When the patient comes back, the complaints are of a chronic, dull pain. That's how it is described. Just spoiler alert, if you will, that is not how trigeminal neuralgia presents itself. Almost the very opposite of it, with a sharp, lancinating pain, kind of, it's why they call it sometimes the suicide disease, colloquially is called that, because the pain is reported as so horrific by patients that there have been at least reported cases where patients did take their own lives because they couldn't cope with that pain that would just come spontaneously for apparently no reason. In any event, the patient reports the chronic pain, dull, but persistent. The oral surgeon at that point looks at the area, finds everything clinically looks good. Sutures are removed, and patient is sent home and told to return if the symptoms don't improve fully by about a month. So let me just step in and interject kind of a risk management thought here. And that is, if a patient is experiencing symptoms, and that is your patient, you're following that patient, I think it's more prudent from a risk management standpoint to not say to the patient, if you're not doing better by a month out, then come in, you initiate the return visit to see me. But in reality, what probably would have been more prudent, and we'll see how it plays out, just tell the patient, no, I want you to come back in a week. Let's see how you're doing. Let's follow you tightly so that we can see if there's anything going on or if things slowly improve over time. And if not, I, the oral surgeon, can potentially make some referrals. This way you have control over your patient. And I don't mean that in a negative way. I mean, you're just supervising what is going on. And you become the first to know if there's a problem that is ongoing or worsens. By comparison, what happened here was different when the patient has said, oh, why don't you come back in about a month if you're not better? The patient felt, for whatever reason, that she was on her own for that period of time, and she goes to her primary care physician. And primary care physician really was not familiar with what to do, didn't have a good handle on it, not unexpected, and refers the patient to a pain management specialist. And that's where things start to become a little bit dicey from the standpoint of where this potential litigation is going to go. Because what the pain management physician says to the patient is, well, this had to have happened as a result of the dental care that you received. Not great to hear, but that's what was said to the patient. The pain management physician also placed the patient on, I don't like to use the name of the medication, but you could probably figure it out. It's a very well-known drug which is used for neuropathic pain. It's also sometimes used for patients who have seizures. And there are probably several drugs within that grouping, but that's what was prescribed for the patient. The patient did not really like it, so to speak, some side effects, which are not uncommon with it. And the situation did not improve. And the pain management physician put a name on it of trigeminal neuralgia. How? I don't know. Why? I don't know. From where I sit, it doesn't seem to match the symptoms. The pain management physician also got a CT and an MRA of the brain, and findings were normal. There was nothing out of the ordinary. So if I'm going to digress for a moment and we'll talk about trigeminal neuralgia, as a general rule, it's caused by, the way I usually describe it to people is, if you take a wire that you plug an appliance in with, it has this kind of a waxy rubberish sheath over it. So if you take that wire and place it immediately adjacent to something which is pulsating over and over and over again, effectively rubbing against that wire over many, many years, that is going to erode away that waxy rubberish coating over the wire, and it's going to expose the copper or whatever is actually internal to wires these days. And it's going to create, I guess, the equivalent of a short circuit. And that's, although pardon the pun, but the jury is still out, so to speak, on what the actual causes are of trigeminal neuralgia. But that is one of the going thoughts on it, that it's all about a proximity between a branch of the trigeminal nerve in the brain and a blood vessel closer, generally an artery or arteriole, which is pulsating, which would explain essentially why it's a disease of middle age, because it takes many, many years for that slow erosion of the outer sheath to dissolve away, so to speak. There are other causes potentially thought of, and a tumor can be a cause. Certain demyelinating diseases like multiple sclerosis, head trauma. But that's basically the thought process. But among the truists in trigeminal neuralgia, they don't view that a peripheral insult, such as a dental procedure, apico, extraction, placement of an implant, is going to be the causal factor of trigeminal neuralgia. But as we often face in litigation settings, when we're defending practitioners, we are presented with a set of facts, a set of records, and we have to live with them. We have to go by them, and we have to make certain assessments about what those records are going to translate to, how they're going to play out in litigation, and how we best defend. So those are pretty much the facts, at least from a dental/medical standpoint. The patient, because I'm talking about it, the patient ends up in a lawyer's office, and the lawyer talks to the patient, gets the patient's side of the story, looks at the medical records, does whatever consultation he may have done with experts, or maybe not experts, but does what he needs to do for due diligence, and starts a lawsuit, both against the general dentist. The theory there was that there was too much pressure placed on the endodontic file, and that caused it to break off, and that caused the whole cascade of events which followed. That was the general theory there. The theory against the oral surgeon was essentially that the semilunar incision that was made in the gingiva in order to gain access to the apex was too high. And therefore, when you use the periosteal elevator to pull the tissue up and out of the way, it infringed upon the infraorbital nerve. That was the theory. Whether I might agree or disagree, that's the theory. And
That's really high up.
it is really high up.
That's really high for an apico.
Right. But if you think about it, these theories, if it can be brought forth by an expert on behalf of that patient, now plaintiff, if they believe it and they speak to it under oath in trial, you're convincing a jury of it. So I agree with you, Brendan. That's really high up. But does a jury know that? Definitely not. And,
no, I don't.
And perhaps you bring in as a demonstrative evidence a skull, and you show where the foramen is, and you show where the tooth is. And, it's not like it's a mile away. It's a matter of, maybe it's a centimeter away, or perhaps even less, depending upon the individual circumstances. So that's the picture that is painted. And the argument is that incision was improperly made so as to cause an injury to that branch of the trigeminal nerve, which thereby caused trigeminal neuralgia, which is unrelenting in this patient, but not in a sharp lancinating pain way, but as a chronic, dull type of pain. So what happened here was not something we see all the time, but these two defendants, the general dentist and the oral surgeon, who were both named as defendants in the case, they were represented by the same attorneys. So I say it's something we don't see all the time. It's something that attorneys have to be careful about. You don't want to create any conflicts. You don't want to be in a position where by advocating for one of the defendants, you're putting the other defendant in a hole. So you have to be able to say to yourself and actually demonstrate as things move forward, I, the attorney, can effectively do that. And if in the course of litigation, it turns out, well, I thought wrong, I can't do it, then it's incumbent upon the attorney to say, we need to step back here for a second. We need to have separate representation of the two defendants. So it's a situation that does happen at times. It's not rare, but not the most common either. They were both insured by the same insurance carrier, these two practitioners were. And they also both had a consent policy, meaning that they had the option to say, no way, I'm not settling this case. If I'm going to have to pay money through my insurance company, it's going to be because a jury told me, but I'm not settling the case. And if you have a pure consent policy, that's how it plays out. If on the other hand, they said, I don't want to go to trial, I want you to settle, you can't force the insurance company to settle, but you're at least giving them permission to do it. It's more of, I'll liken it to a permission slip rather than a requirement slip, to use that type of vernacular. But anyhow,
Right.
They both opted against settling, and they went to trial. What was interesting in this case is that the attorney who represented the plaintiff took an attack on how the case was to be litigated. Whether it was accidental, intentional, strategic, I can't say. But what he did was say, I am going to plead one and only one injury, trigeminal neuralgia. Usually what we see, even if something like trigeminal neuralgia is claimed, we see other less definitive types of complaints of damages. Pain.
Right. They want to throw as many darts at the board as possible.
Yes. Yeah, that's the usual way. But I guess this attorney was of the belief that if I just pick one, it's very serious. I'm going to focus everything on proving that this patient has that disease, and that's what I'm going to go with. It turned out to be critical in how the litigation turned out. Not critical, I mean, there was nothing that either dental practitioner did. It was a lawyer's decision which had a significant impact. And what was that impact? This was after all of the experts testified, and then the jury has the case at that point. So the jury is deliberating in some room off the courtroom, and they have the option to send notes to the judge. And they send a note to the judge, and they ask the judge, can we consider any other injuries besides trigeminal neuralgia? Some other nerve injury, some pain syndrome. And the judge, which sounds to me, I wasn't involved, of course, with the deliberation process or the judge's response, but the judge said, no, it's either trigeminal neuralgia or it's nothing, because that's how the case was pled. And in a short time after that, the jury came back and rendered a verdict in favor of the defendants. And we can draw whatever inferences we like to or what seems reasonable. When I hear those facts, says to me, I wouldn't bet against the fact that if the judge had said, yeah, you can, if it's anything to do with any nerve injury, that would be okay. Maybe that jury would have found in favor of the patient instead. But they were limited because of a decision made by the lawyer. Lawyers make decisions, and it sometimes directs the entire pathway of the case. So what happened like prior to that was that experts testified. In many states, you cannot have the same expert testify to standard of care for a general dentist and an oral surgeon. Some states you can, but some states you cannot, because the expert needs to be of the same type of practitioner as the defendant. So you might have a standard of care expert different for both the general dentist speaking to the quality of the endo procedure here, and another expert on behalf of the oral surgeon speaking to the incision and its location. And as you alluded to earlier, Brendan, yeah, I mean, the experts said what you would expect them to say. The plaintiff's experts said, too much pressure caused the file to break. Too high an incision caused an injury to the infraorbital nerve, which led to trigeminal neuralgia. Other side of the coin, files break. No negligence, files break. The dentist did whatever he could do at the time. The oral surgeon, this expert had actually seen the patient, was able to look at the scar that was left there, said, there's nothing wrong with the location of this incision. It's in a traditional apical incision location, perfectly fine, not high enough by far to cause an injury there. When you can share an expert in many situations is when it comes to the injury and what caused that injury, because that's not practitioner specific, that's a patient issue. So there was, for the defense, a very well-qualified, well-credentialed neurosurgeon who had a good deal of expertise on the subject of trigeminal neuralgia. And the picture he painted was that essentially there is no way that this is trigeminal neuralgia, because that's just not how it demonstrates itself. Yeah. Those are not the symptoms. And the other thing that they said was it's due to an abnormality in the brain. This is not caused by a peripheral insult, as this is argued to be. It's due to an anatomic relationship between blood vessel and nerve. That was a theory of this neurosurgeon. He may also have spoken to other causes of tumor or MS or some other neural diseases, but those were excluded because there were no findings on CT or MRI. And effectively, that testimony appears to have carried the day because it said to the jury, no way is this trigeminal neuralgia, leading to the question of the jury to the judge, hey, does it have to be trigeminal neuralgia? Yes. Okay. In that case over, we're finding for the defendants. And that's how it played out.
That's how it played out. Yeah. What would you say are some of the things, like from a legal perspective? So I mean, this one's pretty tough because I don't know, coming from my perspective, I feel like this is a patient like shooting for a full court shot or a half court shot to try and get a 3-pointer, and while I know it's hard out there financially, I mean, you can't just try and attack providers that are doing treatment on you. And I mean, like you said, files, it's not uncommon. They break sometimes. They're these skinny little metal strings. It's going to break once in a while.
Mm-hmm.
And then with the Apico, like, you got to cut somewhere.
Yeah.
You might even be closer to 10. Well, if you make a vestibular incision, the incision is going to be the same place either way, right? But at that point, the apicoectomy, you're either right there or even lower than the vestibular incision. You're not going up higher. So I don't know, from a anatomical standpoint, it's pretty ridiculous. But unfortunately, in certain states, there's things going on with especially litigation that are ridiculous. And I'm sure you'd agree with that. And
of course,
what can we do as providers in the heart of the thick of the woods of litigation states, the common.
Well, I think that when I look at what these providers did, at least by the reports and the records, they seem to have done everything by the book. I mean, I don't see that there was anything that these providers could have done differently. My only quasi-criticism is, and it's not really a criticism of treatment, is that the oral surgeon didn't maintain that patient control for a while. Instead of bringing the patient back, if necessary, repeatedly, to watch them closely. I think what happened there was that the patient probably felt that there was a lack of direct oversight by the person whom that patient felt was mostly responsible for what happened to her. And so I think that figured into it to some degree. And once you start going to other practitioners, you know how it works, Brendan. You ask 10 doctors the same question, you get 10 different answers. Dentists of all stripes know trigeminal neuralgia fairly well, and not a knock on our physician colleagues, but it's not something that they deal with on a regular basis. It's this unusual tangential disease that is, maybe you see it once in your career practice life. So, but we do see it where determinations are made and a name is put on it. And whether it's right or it's not right, that's what the patient gets. And then once the defense lawyers get it, that's what they get. That's what they inherit. And there are a number of plaintiffs' lawyers out there who understand the gravity of trigeminal neuralgia as a disease and effectively advertise for it. Years ago, and it's not that long ago, lawyers couldn't advertise, or if they could, it was just address, phone number, that kind of thing. But you can advertise now as long as it's not fraudulent in any way, as long as you're not violating your ethical tenets as an attorney. And there are attorneys out there who will advertise specifically for trigeminal neuralgia cases. And, they'll describe it to their client or potential client in a way that they, as lay people from a medical and dental standpoint, describe it. And they get cases that way. They might be very effective as litigators. They may be effective in front of juries. They get experts who will go for the position that they are taking, whether they seek them out. I'm not going to say anything other than just seeking out the people who they think will go along with what their theory of the case is, and they go with it. And we got to defend it.
Right. Right. And I'm just thinking about today. I mean, I did 2, 3 apicos today, and a couple of them were in the same areas what this case was. And like, so here's another thing is how do we quantify what's the appropriate amount of follow-up visits, right? Because it's relative. It depends on the complication.
Sure.
I mean, it depends on what procedure you did. It depends on how that procedure went.
Mm-hmm.
Because like for an apical, I always like to see a patient for follow-up, whether it be like wisdom teeth, whether it be apicoectomies, whether it be coronectomies. But then the number of follow-up visits, right? That's another thing. And then because it's like a follow-up visit is purposeful. If you gave every patient a follow-up visit, I mean, we'd be here till midnight every night, So it like you can't do that. But then having one follow-up visit and then say for a coronectomy, do you have another one in 6 months, like 3 months? What's kind of like we don't really have standard. If there were problems, I always make sure to say, if anything comes up, just come back in. We take a look at it. But I don't know. I don't usually follow patients more than 1 or 2 follow-up visits after the coronectomy if everything's sound, But that's just...
Yeah, I think that's probably pretty common across the board. If you asked a bunch of oral surgeons, they'd probably say the same thing. I think what's different in this case, though, what you're describing is essentially a patient who is progressing in a positive way and is either symptom-free or just about symptom-free, and they're very close to that goal line. In this situation, you have a patient who comes in post-op about a week out and is making a specific complaint of chronic dull pain, which she hadn't had prior. So I think that's in a little bit of a different bucket.
It's different situation.
Yeah. Big answer to your question is it's really subjective. And there's no way to say to a practitioner, oh, you must see a patient X number of times after procedure Y. It just doesn't fit, and it would be inappropriate. Plus, there are a lot of things that can get in the way of it, just logistically. So what I think you just need to make a judgment, and as with any judgment, I would say, as long as you have a good rationale for doing whichever side of the judgment scale you choose, I think that's probably the best that you can do, because that's what you would be asked to defend if you were placed in a litigation situation. Why did you do this? Why didn't you do that? And if the best you can do, because you can't guarantee a good result in every situation. How nice would that be? But just not reality. But the best you can do is say, under these circumstances, I took the approach based upon my judgment at the time that this was the most prudent thing to do. What a reasonably prudent practitioner would do under those circumstances.
Right. No, absolutely. And then another thought is, because she did have a follow-up visit after the apico. They removed sutures. They checked everything up. So, I mean, do we have any signs, any symptoms, signs, any reason at that appointment for the oral surgeon to see that patient once again? You know what I mean? It was just because of the situation with the file being dislodged?
No, I think it was because the surgical site by the oral surgeon's description was good. Right. Tissue was well perfused. Sutures were removed uneventfully. No sign of infection. The only thing was her complaint, the patient's complaint of chronic dull pain.
Okay, I see what you're saying.
Which was, she said, whether it's true or not, but you have to go by what the patient says. She said it was really impacting negatively upon her life. And over time, in fact, she reported that to subsequent practitioners. She couldn't even sit and read a book for any period of time because it was that destructive to her, life activities.
Yeah.
Was she exaggerating? I don't know. We can't know. Or was she being totally legit and accurately reporting what she was feeling? But either way, let's assume that she was accurately reporting. That's still not trigeminal neuralgia. It may be some type of atypical neuropathy, that it might be. But just because of the way the case was pled, that was a critical differentiation that was made.
That's a great point. So for all of us listening, if there is a complaint, say, for example, I had a long wisdom tooth surgery This is going back 2-3 weeks now, and the patient says they continue to have like some pain up in this area. Obviously, we know it's probably a muscle strain. Mouth with a small mouth, wide
Mm-hmm.
open for might have been an hour and 15 minutes, and now we're out of the range of normal postoperative symptoms. Normal postoperative, an infection timeline would arise within 2 to 4 weeks, right? And starting to get out of that range. Another one would be the dry socket, right? 3 to 5 days, probably maximum symptoms. And then after a week or so, that should generally resolve. So we're out of that. So it really comes down to just muscle strain. But so this is a great point because it relates to that is that's a situation where you need to continue following that patient, right? Because if they were to go to other providers, they were to go to an attorney to go after this, um, at least the pursuit of this patient to continue to follow them, to continue evaluations, continue follow-up exams to make sure everything is going normal. I see what you're saying. So that's something I would take from this is,
Yeah. And then there's also a cautionary tale that once the patient leaves your sphere of influence, shall I say, leaves your direct care, you're subject to whatever some other practitioner says. So if that other practitioner sticks a name on it, sticks a diagnosis on it, that becomes part of that patient's medical record. And it is. I mean, it's a factual piece of evidence. Can we argue it? Can we disagree with it? Most certainly. But that's what the record is going to say. And that has significant import and significant weight when you get into a trial situation before a jury.
interesting.
Yeah. And let's face it, experts who are there for standard of care, who are there for causation of injury, defining injury, they're paid. They are paid certain sums of money, variable, of course, under the circumstances. But if you compare that with a subsequent treating doctor, in this case, the primary care physician, the pain management physician, that person had no axe to grind. That would be argued by the plaintiff's attorney. They just saw the patient. There was no litigation at the time, no lawyers, no lawsuits, nothing but the patient in front of you who was making complaints. You called it like you saw it. Shouldn't that have some more weight and heft than somebody who's being paid to give certain testimony? That's not an unusual approach that attorneys do make in courts.
Yeah, that is an interesting perspective on it.
Yeah, this is adversarial stuff, and we're used to as healthcare practitioners to be in this world of we're all in this together to try to make a patient better in some way.
Yeah,
But
yeah.
once we get into the litigation world and sometimes events that lead patients to get there, they're not always that way. They become adversarial and can get there very quickly.
That's right.
So it's as I said, a cautionary tale with that.
Yeah, yeah.
Yeah.
So number 6 next month, November, will be GP, and this is interesting. Do you think just patients can go out on a whim and sue a dentist for things when it's like, I mean, I thought this is such a far stretch, calling it trigeminal neuralgia. You got people diagnosing it as trigeminal neuralgia, and probably the primary care physician was like a family medicine doctor, which, they're trying to help, but it just didn't.
Yeah. Yeah. Is it a stretch? I believe so. The patient didn't believe so. She was able, through her attorneys, to get experts who didn't believe it was a stretch, presumably. Presumably, they went into court,
They went to court.
took an oath to tell the truth. That was their opinion. And so we can disagree as to whether we think it's within the realm of reasonability or not. But that doesn't mean that there won't be the other side of the coin that has a different view. That's what makes litigation litigation.
That's right. That's right. So follow-up courses, just to summarize, what else could we possibly have done? Say if we were those providers, continue follow visits with the patient.
Yep. And as always, documentation is so important. I can't emphasize that enough because a jury might be looking at a specific note that was written. So the documentation of it is critical. And you want to make it as contemporaneous to the event as possible. You want to paint a picture effectively of what you saw what you felt, what diagnosis you made, why, what treatment you recommended. That's pretty much it.
This is excellent advice, because we're taking notes every day. I guess that's what it comes down to. It comes down to those notes, the description, the detail from that event while it's current.
Yes.
Because you can't go back and addend these notes from months ago, right? That's not good.
Yeah. Addendums are fine if you legitimately leave something out. Addendums are not so fine if it happens the day after you get a lawyer's letter.
Right.
It smells like something is cooking that's not exactly
What happened here?
Yes.
We got a quick disclaimer, all right? Note that this case presentation includes circumstances from several different closed cases in order to demonstrate certain legal and risk management principles, and that identifying facts and personal characteristics were modified to protect identities. The content within is not the original work of MedPro Group, but has been published with consent of the author. Nothing contained in this article should be construed as rules for establishing a standard of care or as legal, medical, or dental advice, because the facts applicable to your situation may vary, or the laws applicable in your jurisdiction may differ. Please contact your personal or business attorney or other professional advisors if you have any questions related to your legal or medical obligations or rights, state or federal laws, contract interpretation, or other legal questions. Thank you.